All right, it's 2 after 2, so I think we can get started. Can everyone hear me? Awesome, cool. So we'll start with a case. So this is a 60-year-old male with history of uncontrolled type 2 diabetes, end-stage renal disease on dialysis via tunneled line. He's presenting to the emergency room with tactile fever. When you go to see him, he's actually afebrile, his vitals are stable, and you note on exam there's no erythema and no fluctuance over his HD catheter. His white count is 9, blood cultures are drawn, and later that afternoon, you are notified that both blood culture sets are growing coagulase negative staphylococcus. So my first question is, should we worry about the coag negative staph growing from his blood cultures? Yes or no? ×2 from the next door office. All right, so maybe we don't know, which is why we're here today. I would argue, yes, we should be worried. And so my follow-up question is going to be, what is the best next step in managing this patient? Would you A, observe off of antibiotics, repeat his cultures and continue to observe off of antibiotics, repeat blood cultures and start antibiotics, or remove his line and discharge home? Thoughts? All right, lots of silence. Oh, wait, definitely not D. Yes, I would agree. He still needs his HD line, so hopefully we aren't removing his line without a plan to replace it. And yeah, C is probably what I would err on the side of doing. Repeating cultures can always be helpful if you're not sure whether a bacteria isolated is a true pathogen. And given that he's already growing something from 2 different sets of blood cultures, I would probably err on the side of starting antibiotics for this person. Cool. So this Fast Facts Friday is going to be on coag negative staph, specifically coag negative staph bacteremia, because this confused me a ton when I was a resident. On the one hand, we know that it is normal, like it lives on our skin, and therefore is easily introduced into blood culture bottles if improper sterilization is used. And it's a pretty heterogeneous group of bacteria, including a lot of species you've probably heard about, including Staph epi, Staph hemolyticus, Staph lugdunensis, and Staph saprophyticus. But there are also occasions where coag negative staph can be pathogenic. In fact, it is the most common cause of catheter-related bloodstream infections and an increasingly common cause of endocarditis. So while it is the most common blood culture contaminant, there are certainly times where coag negative staph should be treated. So what are some of those situations? One of them would be your patients with indwelling catheters, so central lines, PICCs, or implanted devices like AICDs or even pacemakers. The reason for this being coag negative staph lives on our skin and is easily inoculated or can infect the device or just attach itself to the device at the time of insertion. And once there, it has a tendency to form these sticky biofilms, which make it very difficult to eradicate. I'm going to take a tangent here, but I think often when we envision a line infection, we think of one of these 2 images here, where there's, here on the left, there's erythema and a little bit of purulence at the exit site, or here on the right, there's erythema extending 2 centimeters beyond the exit site. So this would be like a tunnel infection. But actually the most common presentation of a line infection when they've looked at this retrospectively is just bacteremia, plain and simple, without any overlying skin changes. In fact, there was a retrospective study of over 1,000 adults with HD lines like this patient, and they found that less than 5% of those patients who were found to have a line infection had clinical findings at the exit site. So all this goes to show that the absence of erythema, absence of purulence over a patient's line should not eliminate the possibility of them having a line infection. Cool. The second situation where we should consider treating coag negative staph are the patients who have cultures that rapidly turn positive. And by rapid, I'm referring to less than 24 hours after they are collected. The reason for this is because if there is a true endovascular infection, we anticipate lots of bacteria floating around in their bloodstream, which translates into faster growth on the culture plate. In contrast, if it's just contamination from faulty sterilization methods, we'd anticipate relatively low amounts of bacteria in the blood culture bottle, which translates into slower growth on the culture plate. And finally, the last situation where you should consider treating coag-negative staph would be your patients who have multiple sets of positive cultures. Note that I'm referring to sets of blood cultures and not bottles. And sets are usually taken, or should always be taken, from different sites on your patient at different times. So unless you have very faulty sterilization techniques being used multiple times, probably by multiple phlebotomists in the hospital, if multiple sets are turning positive for the same bacterial organism, it is very likely that that is a true bacteremia or a true pathogen and should be treated as such. Cool. So how do we treat coag-negative staph? It's important to know that over 80% of coag-negative staph are methicillin resistant, meaning they carry the MEK-A gene. And in the age of like biofire identification, I think it's important to point out, so that'll look like MEK-A positive, staph detected, but not Staph aureus. Oftentimes I've seen how staff make the mistake that when MEK-A is detected, that means it's Staph aureus, but just know that other staph species can also be MEK-A positive. And treatment of coag-negative staph hinges on whether it is methicillin sensitive or resistant. So if sensitive, IDSA recommends we reach for napsilin or oxacillin, and if resistant, something like vancomycin. And usually coag-negative staph is very easily treated once we know its susceptibilities, but there are occasions where you may need to remove the patient's device or central line, and those situations would include persistent bacteremia despite antibiotics, evidence of the exit site infection, like pictures like I showed earlier, or evidence of metastatic spread, meaning the infection has spread beyond the initial source to other parts of the patient's body. So just recapping what we've learned so far today, remember that while coag-negative staph is the most common culture contaminant, there are situations where it should be treated. Some of those situations include your patients with indwelling catheters, implanted devices, patients with cultures that rapidly turn positive, or patients with multiple sets of positive cultures. Remember also that the physical exam is very insensitive for diagnosing bloodstream infections. So the absence of erythema, absence of purulence at the line should not reassure you that they don't have a line infection. And treatment of coag-negative staph hinges on whether it's methicillin sensitive or resistant. So if sensitive, choose an anti-staphylococcal penicillin. If resistant, choose vancomycin.